Okay, go ahead, doctor.
Thank you for that introduction, and thank you for inviting me to speak to your group. I wasn't quite aware that you wanted me to speak about the role of the oncologist, so maybe we'll just leave that for Q&A. And I also am not planning to speak for an hour, so probably more like 40 minutes, and then hopefully Q&A can wrap up by like 8:15, ideally for my life. But I am going to talk about the new hormonal agents because I understand from some of the members or moderators, there are questions about some of the new hormone drugs and where they're utilized. And then, of course, I didn't want to do a presentation without sharing with you some of the exciting work we're doing with immunotherapy for prostate cancer at City of Hope. So when we talk about hormone therapy for prostate cancer, we have to look at all the different places that hormones are produced in the body that the cancer could use to grow. The mainstay, of course, is castration, so turning off the testicles, and that's done by hijacking this brain testicle system using what's called GnRH or sometimes LHRH agonists or antagonists. So when you use an agonist, that means it's a stimulant. So a shot of Lupron tells the testicles to make a lot of testosterone, and then there's downregulation of the system, and then the testicles are told to shut down. So testosterone goes up before it goes down. With the newer antagonists like daguerreolex and relugolix, that signal is just shut down. So testosterone production drops much more quickly. Then we go over to the adrenal gland, which makes some androgen precursors. That's abbreviated in this diagram as AP. And this is the primary site of action of abiraterone, which blocks CYP17, which is used to convert hormone precursors to salt steroids, sugar steroids, and sex steroids or testosterone precursors. But CYP17 is also used in the cancer cell. So sometimes we talk about the cancer starting to produce its own testosterone, and abiraterone probably exerts some of its effect by preventing the cancer from making its own testosterone using androgen precursors. I'm not going to really address 5-alpha reductase inhibitors because they're not really central in treating advanced prostate cancer. But over here, we get to the androgen receptor inhibitors. So when testosterone comes into the cell or is created in the cell, it ends up binding, well, it's mostly converted to DHT, which is the more potent form. It binds to the androgen receptor, and that takes it into the nucleus and affects what DNA is being expressed by the cancer. So that's how it impacts cancer behavior and causes it to do things like grow or spread. So these drugs block that binding and block the movement of testosterone into the nucleus of the cell and block then the downstream signaling that testosterone would create. And so these are the drugs that end in lutamide. So bicalutamide is an older generation, as well as nilutamide and flutamide. The newer ones are enzalutamide, apalutamide, and darolutamide. So a little bit on the LHRH agonist and antagonist. How do we choose between them? Well, I typically prefer an antagonist, but there are some, because as I said, just drops testosterone. It's, more effective. And so I prefer them in most patients, but there are some exceptions. But if a patient has significant cardiovascular disease, we know that these drugs, daguerreolex and relugolix, seem to be safer in terms of fewer heart attacks and other cardiovascular events in men who have a history of cardiovascular disease. So I'm really going to push people to do one of the antagonists in the case of significant cardiovascular disease. Also, patients who have had androgen deprivation in the past and really struggled with side effects, one of the nice things about the antagonists is that they wear off more quickly. So we know they're going to have relief of their symptoms more quickly when we are ready to stop. And I've had a few patients over the years where the testosterone level was just not adequately suppressed by one of the agonists like Lupron or Zoladex, and I have switched them over to Daguerreolex, because back then relugolix didn't exist, and was able to get the testosterone more suppressed. So when do I still use an agonist like Lupron? Well, the relugolix at least wasn't studied with abiraterone or apalutamide. So for those patients, if they don't want the daguerreolex shot, then I'm going to end up using Lupron or Zoladex. Some men also just really can't make it into the clinic every month. And so doing the 3-month injection or even a 6-month injection sometimes is more convenient. And then those without prescription drug coverage can't get relugolix. The cost is prohibitive. So then it comes down to whether they can do the monthly injection. So looking at the disease states is important if we're going to try to understand where the different drugs are utilized. Most men start out, as you probably are well aware, with localized disease because of PSA screening. We catch most of it early. And they're treated with things like surgery or radiation. And then, although that's successful most of the time, about 30% will relapse, and that's manifest as a rising PSA, or what we call biochemical recurrence. Then we get to kind of a fork in the road. So you have your rising PSA and you do a scan. You might end up finding locations where you see cancer spread, which would be metastasis. And so you might go right into metastatic hormone sensitive, or some men are already diagnosed that way. When they first get their PSA checked, maybe it's quite high and maybe the scans show already spread. Otherwise, for a lot of men with rising PSA, we treat them with intermittent hormone therapy. And then at some point they'll develop castration resistance, meaning PSA is going up even though they're continuing to get their daguerreolex or their relugolix or their Lupron or whatever the case may be. And so that defines this non-metastatic castration-resistant state, provided the scans are still clean, which often they are. So, PSA goes down on Lupron or daguerreolex, and then we continue that testosterone suppression. PSA goes to 0.4 and then 0.8. We do the scan. We're often not going to see any metastases. So this is where all those new lutamides really play a major role. So we'll look at that in a moment. Otherwise, maybe already that we find metastases and we end up with metastatic castration resistant. So you can either get there by starting out metastatic and you start your upfront hormone therapy and then become castration resistant, or you can go through this temporary non-metastatic castrate resistant state. Oh, so we also call hormone sensitive castration sensitive, which is actually a more correct term. Since these hormone drugs work, obviously, once castration resistance has developed. So these are the main hormone drugs that were sort of brought to my attention that might be of interest to review tonight. So abiraterone was initially studied in metastatic castrate resistant, and then they moved it up front to castration sensitive, or like right when you're diagnosed with metastatic disease, you start your Lupron, you also start your abiraterone. Apalutamide came along later, and so their first big study was in the non-metastatic castrate resistant space. And then they got approval in the upfront hormone sensitive. Darolutamide for right now only has reported the trial in non-metastatic castrate resistant. So I see some people using it in other disease states. And of course that makes logical sense. These drugs are very similar, but to be on label, technically, this is the only place it's currently approved. Enzalutamide has approval in all the spaces. So whether you're newly diagnosed metastatic, whether you're non-metastatic castrate resistant, you can use enzalutamide in any of those. There's level 1 evidence for all of that. Relugolix is a little bit complicated. The HERO study allowed men with different types of disease states. So personally, I think it really can be used in any setting where you're looking for castration, and it largely can just be substituted for any of the injectables. However, it hasn't been studied in combination, and there are some drug-drug interactions. So theoretically, we shouldn't use it with abiraterone or apalutamide because we just don't know if it's safe. So if we want to be doing combination therapy, and we want relugolix, then enzalutamide is the only one that had some patients on the HERO trial. And so there's some evidence that it can be done safely. Hopefully, now that people are using relugolix broadly, there will be data emerging about how this performs in real life. So we submitted some data to GU ASCO for our first 50 patients, and we actually probably have 100 patients already on relugolix, some of whom are taking it in combination. And so it takes that kind of experience, unless the drug company is going to do trial after trial, then that kind of experience can help fill in some of the gaps. We've been happy with it. I think our patients have been pretty happy with it. So how do we choose between these drugs? Well, can we choose based on efficacy? The answer is really no. If you look, these are the 3 big trials for non-metastatic castrate-resistant: apalutamide, darolutamide, enzalutamide. All had their nice names for their trials. They were all really large. They all took men who had a fast doubling time. So not every man who develops rising PSA while on Lupron for biochemical recurrence really needs these drugs, but men with a fast doubling time really benefited in all these trials. So they all, I didn't have kind of the punchline in the slide, right? They all dramatically delay the time to metastasis, and they all prolonged survival. So it was something like, I forget if it was like 10 or 15 months till metastasis if you just took placebo, and it was like 40 months with any one of these drugs. So a really significant delay. And that was actually used to approve the drug. Only later did the survival data come out and show that, which is pretty remarkable because patients go on to get all kinds of different treatments after this, that we could show a survival benefit to starting this earlier really speaks to how important it is to hit the cancer hard as early as possible. And it fits with the whole pattern of what we've been seeing in prostate cancer over the last five or 6 years in the metastatic hormone sensitive setting. The more things we seem to throw at the cancer early on, the better the remission, the better people do over the long haul. But so a lot of people worry about men being on these drugs. They're more powerful hormone suppression drugs, and you are all very familiar, I'm sure, at least most of you, with the side effects of taking away testosterone. And now we're going for a deeper starvation. But it was really nice to see one after the other, all of these drugs presented quality of life data. And across the board, you can see, like, for instance, here with the apalutamide, these curves are almost overlapping. There are little differences, and this is looking at different aspects of quality of life. They ask things about, emotional function and physical function in various ways. But you can see there's not much difference between the curves in most of these domains. And if you look at the bottom, 86% of the apalutamide patients and 85% of the placebo patients said they were not at all or just a little bit bothered by side effects. So that similarity between the apalutamide and placebo really speaks to the fact that when you add this drug, you don't cost patients, generally speaking, too much in the way of quality of life. There are obviously some men who will have some side effects and even need a dose reduction or need to stop the drug. But when we looked at these whole populations of, more than 1,000 patients, the pattern we saw was not alarming to where, we prolong life, but at what cost? So we think we're doing pretty well with quality of life. But you probably hear people say that darolutamide has the fewest side effects, or darolutamide is the best tolerated. We don't really know, right? Because there's never been a head-to-head comparison. But there was this one abstract presented last year that did a crossover. Patients with castration-resistant prostate cancer got 12 weeks of darolutamide and then switched over to enzalutamide, or 12 weeks of enzalutamide and then switched over to darolutamide. And then they asked the patients, when did you feel better? On which drug did you feel better or have fewer side effects? And I would have expected more men to choose the darolutamide. I was actually very surprised when I saw these data. 48.5% preferred darolutamide, 40% preferred enzalutamide. So I think that speaks to the fact that there's not a clear winner. There's not a clear best drug. If you look at the reasons on the right-hand side, the green and pink bars, why they preferred one over the other, it was, pretty similar, but maybe a little bit less fatigue with darolutamide. They also did look at efficacy. I mean, a little backhanded way of comparing efficacy for that first 12-week period, and it's really very similar. All right, so in the setting where I have to choose a lutamide, I do tend to prefer darolutamide, but you can see the data don't necessarily justify that. What about when I can choose from abiraterone or a lutamide? So like a metastatic hormone sensitive, like a newly diagnosed patient where we're going to use upfront intensification. There is one study, the Aquarius study, that looked at fatigue and cognitive changes in men taking abiraterone or enzalutamide. So this was like a European registry where doctors selected whatever treatment they wanted to, and then they just put them in this registry to collect the data, so that this wasn't a clinical trial like formally randomizing or asking the question like really scientifically. It's just, an important sort of registry study. And they asked about cognitive impairment, and you can see the enzalutamide here a bit higher for perceived cognitive impairment, 76% versus 49% on abiraterone. Same thing as sort of fatigue, 79% versus 53%. So this mirrors my experience, I will say. And so often when I'm meeting a new patient and we're talking about which drug to use, I tell them that I have kind of a bias towards abiraterone because fewer of my patients need to lower the dose or stop the medicine due to side effects like fatigue or cognitive changes. And there's also, in my experience, sometimes some, like rarely, but sometimes there's anxiety or depression that I feel like can be seen with enzalutamide. So, those are just things that I talk to the patient about. There are sometimes reasons we choose the enzalutamide. Some people have comorbidities, and we'll go through that in a moment, or are nervous about taking the prednisone that comes with the abiraterone. Sometimes insurance dictates, but these types of data are helpful for physicians and patients having conversations and making shared informed decisions together. All right, so we're going to go through the drugs a little bit one by one, and some kind of ways that I choose which patients I'm going to use them in. And the way I frame this is, well, what side effect am I really concerned about? So with abiraterone, there's emerging data that there's a little bit greater cardiovascular risk, things like rhythm problems. There can be some fluid retention, so like congestive heart failure. Maybe you want to not choose abiraterone. So this table is pasted from the New England Journal, showing some of the side effects of abiraterone compared to placebo. There was fluid retention, slightly higher than placebo, and cardiac disorders, hypertension, a little bit higher, not dramatic. But there have been other studies that have just raised this as a bit of a concern. And on this table, actually, I think abiraterone's on the right, even though I cut that off. So it's not that I would never use this, but when I have a choice, I might use the lutamide first and save the abiraterone for later. One caveat to cardiovascular disease is some cardiovascular disease results in anticoagulation or blood thinning. And then there's some more worry about drug-drug interactions with the lutamides, and so I might choose the abiraterone. For apalutamide, this weight loss and falls signal, it's not that much more than placebo, but it is more. So if I have a more elderly patient who's already a little bit borderline, but functioning, I really worry about like tipping them over the edge to where they lose function. And so I might choose the abiraterone over the apalutamide for them. For darolutamide, this is this side-by-side comparing it to placebo is why people talk about darolutamide having the best side effect profile, because aside from fatigue, which is definitely a little bit more than placebo, right? 12% versus 8.7%, many of the others are not that far apart from placebo. So we can't compare darolutamide against other drugs aside from that one study I showed you, the Odenza. But what we can say is, when it doesn't have many more side effects than placebo, then that's a pretty good statement that it's maybe not causing too much cognitive disorder. You can see the difference with placebo, very minimal, and not necessarily increasing falls. So if this drug were approved in all the disease states, then, it would be a nice choice. But right now we just have it for non-metastatic CRPC. Enzalutamide, similarly to apalutamide, has like that weight loss falls kind of signal. And so we might want to avoid it in those more elderly or frail patients. The seizures you probably have heard about. They came from earlier studies when they used higher doses of enzalutamide. It's really very safe, but nevertheless, if someone has a history of seizures, we tend to choose abiraterone first before one of the lutamides. All right, so one of the things I was asked to maybe talk a little bit about is sequencing these drugs now that we've sort of positioned them in the different disease states and talked a little bit about why one might choose one over the other. There's sort of three major ways that men can progress to castration resistance. So on the right-hand side, this is how all men used to progress to castration resistance. Before we were giving upfront intensified therapy, they were just getting ADT or castration. And then we would get to choose whether we used Abi or Enza or chemo, and we might throw CYP-T in there, Provenge. But nowadays, this really only happens if someone develops, they're on maybe ADT for biochemical recurrence, and then when they become castration resistant, lo and behold, they're metastatic. Otherwise, most people are in these first two columns where they either start out getting doublet hormone therapy, ADT and Abi, ADT and Enza, or they get upfront chemo. So then when they cross this red line to castration resistance, it's more of a question mark about CYP-T or Provenge. It wasn't studied in this kind of patient population. Abi and Enza didn't exist when CYP-T was being studied. But I still think there are definitely some patients with slow progression for whom CYP-T is very, very appropriate, and I absolutely still use it. All studies ongoing seem to indicate a survival advantage to men who get CYP-T compared to those who don't. Not every man qualifies, but it's something that should at least be thought about. But then once you are progressing with a drug like Abi or APA or Enza, we know that the other drug's not going to work very well. And so we tend to try to sandwich in something a little more like cytotoxic chemo or radium or maybe a PARP inhibitor if you have the right DNA mutation. So that's why I have on the left-hand side here genomic profiling. If it hasn't been done before, when a man crosses over into castration resistance, we really need that genomic information because otherwise we don't know if a PARP inhibitor is even an option. I will say that because most of the studies with PARP inhibitors were in men who had received chemotherapy, I sometimes get pushback from insurance when I try to order a PARP inhibitor as the first thing out of this box. But in the PROfound study with Olaparib, there were some men who hadn't had chemo. And so sometimes you can at least get Olaparib, even if they'll reject the Rucaparib. And then once we have progressed on both a chemo and a hormone, then we can either go to second-line chemo with cabazitaxel. We, again, really want to know the DNA because maybe that opens the door for additional treatment. And I saw a patient today who first had Abi and then had docetaxel, and now what do we do? I think at that point it's reasonable to go to the other hormone drug. So something like enzalutamide. Maybe we've eliminated the resistant clone, and maybe now we can use that second hormonal drug more successfully. Hasn't been proven, but it's something that a lot of us talk about and do. All right, but one of the most important things is that we don't want to abandon a drug too soon. PSA, this was published by Howard Scher, who's, a famous prostate cancer guy at Memorial Sloan Kettering. This is a patient who starts enzalutamide, PSA drops really nicely. And each of these arrows is CT and bone scans. So he's doing CT and bone scans every 12 weeks, if that gives you a sense of time. So 4 arrows is essentially a year. So PSA is rising so slowly, but no new cancer showing up on the scan. Patient feels fine. The only thing that's changing is PSA. Then we really try not to abandon that treatment, because you can see we would have cut short years of cancer control by bailing on the drug just due to PSA. And you also have to recognize this is PSA on a scale of 1, 2, 3, 4, right? It's not going from 1 to 100 to 1,000. Obviously, we might change for that PSA trend. But here, the patient finally develops real clear progression with maybe a painful bone site. And Dr. Scherer gives radiation and the PSA drops. So this is a fun trick. It doesn't always work, but sometimes the cancer is all controlled and the resistant group is really only growing in one place. If so, if we radiate that place and kill that resistant clone, then we can get back to the rest of the cancer that's being in control and extend the life of that treatment even longer. So again, I don't want to, get people's expectations set too high. This does not always work. But I was really happy when I saw this publication, because this is something that we do not uncommonly, especially now that we have these fancier PET scans, also that although they haven't been shown yet to work this way, we'd like to think maybe they show us where is the active cancer in a way that it's been harder to do with standard CAT scans and bone scans. But the bottom line is we try not to abandon a drug just because of PSA. We have to look at how the patient's doing, how the imaging looks, the scans, and also what are we going to next? If we're going to chemo next, do you really want to do that because your PSA went from 1 to 2, even though you feel fine and your scans look fine, right? So I mentioned earlier that we don't tend to like to go from Abby to Enza or Enza to Abby because they're not as effective one after the other. And that you've probably heard this ARV7 story. The androgen receptor, that is the target for both of these drugs, mutates in a way that makes them ineffective. So the ARV7 bars are yellow. Going up means cancer's growing. Going down means cancer's shrinking. And you can see that when you use Abby after Enza or Enza after Abby, top and bottom graphs, like the yellow bars just aren't going down. So if you have this ARV7, you're really just not able to respond to Abby or Enza. But importantly, Emmanuel and Tonarakis, who did all this work, which was so impactful, showed that chemo, you could still respond. So the light gray bars have that ARV7 mutant and still respond to Taxotere chemo, docetaxel. And so that's why I was saying we sometimes, we'll go from Abby to Enza or Enza to Abby with the Taxotere in between. Like we hope maybe we wiped out the ARV7 clone and maybe the rest of the cancer doesn't yet have that and could still respond to the other hormone drug. Not proven, hypothetical, but something that a lot of us talk about and a lot of us do. Another question about sequencing comes with what to do after, let's say you start with your ADT with Abby, and then when you're progressing, you go to Taxotere. Now what? So the CARD trial asked the question of should you go to the other hormone drug or should you go to cabazitaxel, or Jevtana, you might have heard it called. So this was not your average prostate cancer population. 70% of them came onto this study because their cancer pain was getting worse, and that is really not most of our patients, thankfully. But that being said, there was definitely a much stronger response to the cabazitaxel, the Jevtana. And the side effects, if you look at the severe side effects, 56% versus 52%, people think about chemo as, oh, I'm going to have all these side effects. Cabazitaxel is actually pretty well tolerated, and cancer causes a lot of what we call side effects in this later phase of the disease. So a lot of doctors said, oh, we should never use Abby after Enza or Enza after Abby. I don't think never. I think there are some patients where we're just not ready to jump into Kabazi and a trial of the other AR agent. Maybe it only gets them 3 months, but it's 3 months on a hormone pill instead of on chemo, right? So, and during COVID, we had to weigh the risk of immune suppression. So every situation is much more complicated than what the data look like, but the data are helpful when we're weighing the relative risk and benefit. And the CARD study clearly favored, if you've had Abirenza and you've had Taxotere, cabazitaxel is really a good choice to go to. Can't say it's the best because there are still other options. Like we don't know how this would have compared to a PARP inhibitor for men who are eligible, for instance, right? So I can't say it's the best, but it's definitely better than going to the other hormone pill, unless there are reasons that make you need to go to the other hormone pill. So Profound was the similar study, so kind of like CARD, but with the PARP inhibitor Olaparib, or you may hear it called Lynparza. So this took men who had progression of their cancer despite Abi or Enza, and now they're going to get randomized to the PARP inhibitor or the other hormone pill. So similar design. Most of them had a previous exposure to Taxotere, but not all. And they studied this primarily in BRCA mutated prostate cancer. PARP inhibitors were initially approved in breast cancer where there's a BRCA mutation. But in prostate cancer, they also studied it in a broader set of mutations. So they included ATM, and then this other included things like CHEK1, CHEK2, PALB-B2, CDK12, RAD51. So there's a whole list that qualified you for this study. And those lesser mutations were studied in cohort B. So this was a randomized level 1 evidence kind of a trial. The initial presentation showed that it took twice as long for the cancer to progress or grow in a bad way using the Olaparib as it did on the other hormone drug. But also importantly, survival was prolonged. So again, rather than going from Abi to Enza or Enza to Abi, we try to look for something that we think will work better, whether that's cabazitaxel or maybe a PARP inhibitor. But what's next? Sequencing is going to get more and more complicated as we get new drugs, but that's a good problem to have. We want to have choices. We want there to be more than one path because every man with prostate cancer is different, and we want to try to treat people as individuals and choose from our treatments based on not just their cancer characteristics, but also lifestyle. And so lutetium-177 PSMA will be a really nice addition to our toolbox. I'm sure you've had speakers on this. I'm sure you've heard about it. I think I have another slide on it, so I won't say more here. PARP inhibitors are maybe moving earlier. I don't know if you heard, there was a press release from the phase 3 study, PROPEL, where they took any man with prostate cancer. They didn't look for the DNA repair mutations. So it didn't matter if you had BRCA or ATM or any of those mutations, any man with metastatic castration-resistant prostate cancer, and they randomly assigned them to abiraterone alone or abiraterone with Olaparib. And we had a press release saying that it was positive. So in the phase 2, they found the signal of progression-free survival. There were increased side effects. They went into phase 3, and now all we know is that it was positive for the main endpoint, but we don't know by how much or what the details are or how those side effects played out. So we're hoping to see those data early next year. And then we'll be able to decide maybe now every man will be a candidate for a PARP inhibitor, which could be exciting, and will change how we sequence treatments. We still need durable remissions. I think some men over the years have expressed to me disappointment. We thought Zytiga or abiraterone and Xtandi, enzalutamide, we thought they were such breakthroughs. I mean, we literally saw how much it changed how long men lived and how well they lived. But from the patient side, it was like, oh, this made my PSA go down for a while, but now my PSA is going up again. Like, why do we always get resistance? So that's where I believe immunotherapy offers the greatest hope. It may not give everyone a remission, but when it does, it could give really long lasting remissions, which is something I think that the prostate cancer community has been very hungry for. Okay, so yeah, I do have a couple slides on lutetium 177. I'll go fairly quickly because you've probably seen this before, but the big phase 3 was presented by Michael Morris last year. The blue line is the survival for the lutetium. The yellow line was standard of care, which really wasn't much. They could get like Abby after Enza or something like that. They couldn't get chemo, they couldn't get radium. So it was a limited sort of standard of care. And the response is clearly many more men had their cancer shrinking, right? The lines going down on the waterfall plot means less cancer with the lutetium compared to the standard of care. What I thought was more compelling and also speaks to sequencing was the therapy trial. So this was a much smaller trial, but it was presented also last year. It compared lutetium to cabazitaxel. So there's an active comparator, right? I already showed you the CARD trial where cabazitaxel was more active than Abby or Enza after exposure to one of the others. So now lutetium bests cabazitaxel, which is quite an effective drug. So you can see a lot more bars going down, a lot more responses with the lutetium. So I find these data very compelling. And if a man has progressed on abiraterone and then taxotere, docetaxel, if I have this versus cabazitaxel, this is dosed once every 6 weeks. You don't tend to get so neutropenic. You don't lose your hair. I mean, you can have dry mouth, but overall, the side effect profile, in my view, I haven't used it personally, right? Because it hasn't been available yet. But in my view, this seems better tolerated and will certainly be a really nice option. We will still use cabazitaxel, but it's just a question of which one we might use first. So I already talked through most of this. So I think radiopharmaceuticals like lutetium are going to eventually pop up earlier into the sequence. I know there are already plans to study them in castration-sensitive settings, but they're certainly going to be added into the various boxes as an option, and sequencing will remain, something that there has to be a lot of discussion about. And eventually, hopefully, we'll have predictors, something that says, okay, this man will respond better to cabazitaxel and this man will respond better to lutetium, right? We would all love to have more guidance as to what will help an individual than we have currently. So I'll finish up with just a little bit on immunotherapy. I promise it's just a couple slides. So this is from our recently published review of CAR T and BiTE antibody therapies for prostate cancer. So on the top, you see the BiTE antibody. So it is an antibody that has one head that sticks to a tumor antigen. So often it's PSMA, but we have a BiTE also targeting STEAP1, which is a different protein expressed on prostate cancer. And then the other head of the antibody sticks to a T cell using CD3. So how does that work? Here's the two-sided antibody on the right. The blue grabs the T cell, the purple grabs the cancer cell, and it brings them together so that the T cell will kill the cancer cell. On the bottom is the CAR T. So what we do, we take out a man's T cells. The T cells want to attack different things. This one wants to attack a virus. This one wants to attack a fungus. We wipe their memories. We put in what we want them to attack. So we want them to seek out, in some cases, PSMA. In the case of City of Hope, we have one also targeting PSCA. And then all these T cells now are looking for that. And we make hundreds of millions of them. And then we administer them once. Whereas the BiTE antibodies you're given every week or every 2 weeks on an ongoing basis because your body gets rid of it. These CAR Ts can stay. They can produce more of themselves inside your body, which is why in leukemia and lymphoma, with one dose, they were able to cure many, many patients' disease. So that's the hope. We don't know if we'll get there with prostate cancer, but it's nice that it can be a living treatment that stays alive in you and continues to make more of itself so it can continue to attack the prostate cancer. There are also all these bells and whistles that the scientists are making in the next generation CAR T cells. Something that's conditionally activated, something that might have two different targets. It's really amazing how they can engineer these. So It's going to take us a while to get to cure or durable remission, but I really think the CAR T paradigm has that potential. We just have to figure it out and do the work. So these are the only available results from BiTE antibody in prostate. This is with AMG 160. We presented this at ESMO last year. We just submitted more data to GU ASCO for 2022. So hopefully we'll be, actually I think it's for big ASCO, not GU ASCO. Hopefully we'll see more data. But in this first set of patients, we were really excited about a third benefiting because we started at this very low dose and we went up to a very high dose that was not well tolerated. And even in some of the lower doses, we saw patients who crossed this dotted line. So this is a swimmer's plot where anyone who's continuing to take the drug stays as a bar. And so in this lower dose cohort, we had quite a few patients who crossed that 6-month mark, which is pretty meaningful for treatments. These are patients that had 4 or 5 lines of therapy. Often they'd had both Geftana and Taxotere, both Zytiga and Xtandi, right? So they're very heavily pretreated. So this was a nice signal of efficacy. When we presented these data, why don't the higher doses look better? Well, because they hadn't been on the treatment as long at the time that the data were presented. So it's not that the dose that's been chosen to move forward, which is really this 0.3, it's not that men don't cross that 6-month mark. It's just that at this time point, we didn't have those data. So this is, I can already say it's clearly effective. I've seen it drop someone's PSA from 1,000 to 33 in the first month. I haven't had so many patients make it where it's still controlling their cancer at 6 months, but clearly there have been, and it's an exciting drug. 90% of people get fever and chills. It's a rough go the first few doses, but it does get easier. And eventually you come in, you get your infusion, you go home, and you're not having day-to-day side effects. So the fever and chills that we talk about is cytokine release syndrome. So I just wanted you to at least have some familiarity with what that looks like. We used to give the drug in the hospital in case of the cytokine release. That can lead to not just the fever and chills, which are uncomfortable. We can support people through that, but sometimes the blood pressure would drop. And so we would give fluid or sometimes even need to prop up the blood pressure or take patients to ICU. So, and then we have this drug tocilizumab that you may have heard about in the context of COVID that we've used to shut down cytokine release. So that is the bulk of the side effects that we see with BiTE, and it's actually kind of the main side effect with CAR T as well. So at City of Hope, we're studying 3 different CAR Ts now. We've been doing the PSMA targeted from Poseida. We've been doing our own PSCA targeted CAR T that our PhD scientist Saul Priceman created and developed, and we produce it on campus. With the PSMA CAR T, they've had this unfortunate, really aggressive side effect called macrophage activation syndrome. But we've learned a lot as we've been treating patients and seeing it, and we've figured out all these different ways to try to mitigate it. With the PSCA targeted CAR T, we haven't seen that, but we have seen bladder inflammation or cystitis because there is PSCA expression on the bladder. So the T cells go against the cancer, but they can also irritate the bladder. So we're making some modifications to reduce this because it's pretty uncomfortable when you have to urinate every 15 or 30 minutes. Only about a third of patients have it, but we would like to have fewer patients experience that. And then this KLK2 targeted CAR T from Janssen just recently opened, and we'll be treating the first patient very soon. Because it's all about the target at the end of the day. The target defines the side effects. It also may define response. So we want to not put all our eggs in one basket. This slide shows some of the data that Poseida, the company, presented at an industry conference. They said it was public domain. So they have seen these responses in PSA and PET scans. The green bars represent reduction in PET activity, and the blue bars reduction in PSA. And then they showed these pictures of a PSMA PET scan getting better. So it's pretty exciting to see responses because, early on we were really worried about the side effects. But now that we're also seeing responses, it's just a question of working out the kinks and getting the right balance. So this is a close-up of the PET scan. So you can see this is, I don't know how many of you have looked at your CT scans. This is a pelvic bone that's lighting up yellow, means cancer activity. 4 weeks after the CAR T cells, it's less. 12 weeks after the CAR T cells, it's almost normal. So PSA came down, imaging looks better, so a real significant response. This was one of our patients. One of our first patients on the trial, one of our early patients, had a 95% drop in their PSA. The bone mets improved, the soft tissue mets improved. And then we've had this other patient whose liver, this was the pre-treatment, and this is at day 28. Like clearly, the dark spots are cancer, and clearly there's less dark spots on the post-treatment scan in the bottom. We've had some other, we have a lot of bone-only patients, which is very common in prostate cancer. So it's a little harder to see these nice dramatic responses, but we've had definitely stabilization with some PSA drops. But we're still, looking for that durable remission, that kind of holy grail. So in summary, I hope I've given you a better understanding of where all the hormone drugs fit in the landscape, and then also how we sequence them. But also very important for you to know that your path might look different than someone else's, and there are all kinds of different factors that the physicians are using to try to decide what's best for you in this moment next. And sometimes there's not one right answer. I know sometimes patients get frustrated with me. Well, what's the best? Well, I don't know. We have this set of choices and they haven't been tested against each other. So I can't tell you one's better. I can just tell you they have a different side effect profile, and we'll use them all. It just depends what order, right? So try not to get too frustrated with your oncologist if they give you options. I guess try to view it as a blessing and not a curse, to have to be involved in the decision making if you can. All right, so I hope I left enough time for questions.
Thank you very much, Doctor. I have a question from Dr. Metzger. What is your question, Doctor?
Yes, I think I'm unmuted. Thank you, Dr. Dorff. That's absolutely excellent discussion and did meet all the points that we had talked about. I have a patient presentation. If someone comes in with high Gleason score, high PSA, oligometastatic disease, de novo, hasn't had any treatment, is there any place for radical prostatectomy or radiation to the prostate to try and stop the seeding or the further advancement? And then what would you do with the few metastatic lesions that are there? We've had several patients in our advanced class that have come up with this, and we're getting different answers from different local experts. We just would love to pick your brain.
Yeah, well, so the reason you're getting different answers is because there's a lot that's not yet known about the best way to handle that situation, especially if that's the way the man presents, right? So it's a little maybe clearer if the prostate was removed 2 years ago and now PSA rises and you have 1 or 2 spots, 1 or 2 metastases, and they're oligometastatic with no prostate primary. But for your situation that you posed, the piece 1 data, along with data from the Stampede trial, suggests that radiation to the prostate is helpful, does increase survival in the setting of oligometastatic, or low volume at least, metastatic prostate cancer. The problem with the Stampede trial is those patients weren't getting abiraterone or enzalutamide or docetaxel. Piece 1 did rectify that a little bit. So they showed that you still got benefit from abiraterone even if you had had radiation to the prostate. They showed there was no interaction between those two. There's still a lot of unanswered questions, but essentially, yes, I think most of us would say there's strong evidence that for that man, in addition to ADT and Abi or ADT and Enza or whatever you want to choose, you should consider radiating the prostate. It would make sense then also to radiate the other sites, right? The whole goal of the radiation is we know we don't get to zero cancer with the hormone drugs alone. So how can we try to get to zero cancer? Well, we can add a focal ablative therapy like radiation to anywhere where we can actually see that there is cancer, knowing that we won't get to zero just with the hormone drugs, right? Prostate removal, little trickier, not nearly as much data as there is for radiation, but there's actually two ongoing trials that really want to answer that question. And so they'll take a man who's had ADT and ABI or ENZA or chemo or whatever, and even metastasis-directed radiation, and then randomize them to have their prostate removed or not. And that's how we're going to find out, when we're doing everything else, does it help to remove the prostate? And they're looking, importantly, not only at cancer control, but quality of life, because there are some downsides to removing the prostate, as some of you are likely aware, things like incontinence. But there could also be benefits, right? Some of my patients whose prostate has been in there 5-10 years, and we've been controlling their metastatic disease, but that prostate locally starts to block off urinary passageways. Some patients even end up needing to bypass the normal route of urination. So maybe there are going to be benefits to having removed that. And we know different clones can pop out of the prostate later on in the course of the disease. So it's an open question. If you do it, we don't tend to do it right away. We tend to give like 6 months of treatment first and kind of make sure we've got control before we go in and do the prostatectomy.
Very good. And again, once again, appreciate your wonderful talk. Thank you.
Doctor, the next question we have is from Joe. Is anyone studying combining Regulix and ABI, especially NMCS?
All right, so I don't know about NMCS, but what he's asking is relugolix and abiraterone, right, which have not been studied, and there's a potential drug-drug interaction. I'm not aware. I don't know of every study in the universe, so I apologize. There could be a study, but I will say that I've done it. And some of those patients' data will be included in the data I hope to present at GUASCO and write up eventually, because I think it's an important question. You know, right now you sort of have to choose enzalutamide when you choose relugolix for combination. But so technically you shouldn't do it. There probably are studies ongoing, and someday we'll have that answer.
Okay. Here's one from Bob. Radiation was mentioned only later in treatment. Now, my impression that the standard of care is ADT, etc., and radiation of the prostate bed right up front. I think you just addressed this question.
Oh, no, he's talking about biochemical recurrence, and he's absolutely correct. But I was asked to talk about the use of the different drugs, so I kind of skipped over that part of the man's journey. I can't talk about the whole spectrum of prostate cancer in 40 minutes. So you're absolutely correct. When PSA is rising after prostatectomy, we usually do the radiation with or without hormones. And everything I talked about was the unfortunate scenario where it then starts to rise again, despite that.
Does anybody else have any questions? We'll open the floor.
I have a question.
I'm sorry, go ahead. Go ahead, Bob.
Can you hear me okay? Dr. Dorff, the LU-177, which is the new frontier, one of the new frontiers, and it seems to be targeted at the moment with trials after other things have been tried first and not been effective. So do you have any views on that? If it were available somewhere in the world, like in Europe, would that be your first choice or not?
So it is available. I've had patients fly to Germany to get it, or to Australia. Would it be my first choice in front of abiraterone or enzalutamide? No. I don't have any reason to think it would be more effective. If I see some data that show that, then of course I'll change, right? I'm always changing how I practice prostate cancer medicine, right? I think all of us should be, because there's always new information and new treatments, right? So, but right now, abiraterone, enzalutamide, apalutamide, they are powerful, powerful drugs, and it's going to be a while before anything unseats them. So I wouldn't choose it before those. Would I choose it before docetaxel? Yeah, if there were compelling data, probably, because docetaxel has the potential for some permanent side effects like the neuropathy, numbness, tingling, fingers, toes. So the lutetium seems to be maybe better in terms of side effect. It's once every 6 weeks instead of every 3 weeks. So there's some advantages in a COVID world. But, first we have to get access to it. You have to have PSMA positivity. So you have to do the PET scan. On the VISION trial, about 10% of patients didn't qualify because their cancer doesn't have PSMA. So the treatment's not going to work for them. So there's more nuance to it, and we'll have to really see how FDA handles that and how they define who should access it and at what point.
Does anyone else have a question? Either post it on chat or ask the doctor directly. In fact, I'll ask a question. Do we know what it is that turns prostate cancer on? It's a disease we generally only see in men over 50 years of age. And while we're getting more information about the genetics of prostate cancer, we don't really understand why this is a later in life disease.
Yeah, it's a fascinating question, and it's something I was just talking to ZJ Sun, who's one of the scientists at City of Hope who I work with, who's also super interested in the relationship between testosterone and the prostate, and why does that change for some men at some point. I have had some patients in their 40s and even one or two in their 30s who got diagnosed, but generally it is diagnosed later. And at that point, if anything, testosterone levels maybe are dropping a little, although not in all men. And we don't know whether that drop would be associated with it. So I think we need more of the brain trust that focuses on castration-resistant prostate cancer or the development of castration resistance to focus on the earlier question, but it's very hard. I was talking to ZJ, like, how do we get tissue from 18-year-old men from their prostate, right? That we're not going to do that. But, to really understand when does something change and what is that something, it would be helpful to have that, either that or model systems. But ZJ always says, and I think he's correct, that you really cannot mimic the human prostate in animals because there's just complexities about steroid metabolism and like SHBG, which doesn't exist in mice, for instance, that make it impossible to really mimic. So it's a fascinating question. It's something I hope that more people will study and understand what's that change that happens in the relationship between testosterone and prostate being healthy and prostate no longer being healthy. But we don't know right now.
Okay, anybody else?
Tanya, I have a question.
Go ahead, Bob.
Neil, can I speak?
Go ahead.
Yeah, Dr. Tanya Dorff, I had a question about, what are the clinical trials that are being held for aggressive prostate cancer at the City of Hope? I mean, both in terms of metastatic and non-metastasized prostate cancer.
Thank you for that question. I feel like that's a softball, so to speak, because I get to talk about clinical trials, which I love. We have a study that's using PARP inhibitors early for metastatic castration sensitive. So ADT, abiraterone, and we're adding talazoparib, which is a PARP inhibitor that in my experience has a really better side effect profile and really super effective. So, and we're doing a lot of deep science to try to see whether it picks out some of the aggressive clones that might evolve later and knocks them out early, which is what we hypothesize will happen. So we're hoping to see maybe more men achieve remission, but really maybe fewer develop progression later on. Earlier, we have this white button mushroom extract study that's really popular. We had it a few years ago, and there were some men with rising PSA who got this white button mushroom extract, and their PSA went down and stayed down. So they got to avoid hormones. So that's super exciting. But obviously it didn't work for most men, only some. And now we have a phase 2, kind of randomized study in rising PSA and also in active surveillance. So not aggressive, but just trying to help more men keep their prostate and not need radiation or surgery to treat their prostate cancer, right? So still a worthwhile goal. We don't have much that's aggressive for, well, I guess we do have studies in localized disease. We're using a lot of Decipher, which is a molecular, it's not a DNA sequencing. Decipher looks at RNA or protein or like expression, and tries to look at what genes a cancer is using more than others, and can use that to stratify how aggressively a person's prostate cancer will behave. So a lot of the localized studies are asking, if you do the Decipher score and it says, wow, this cancer's behavior is more aggressive and this one's less aggressive, can we individualize treatment, like give less hormone therapy to the ones with a low Decipher score, give more intensive hormone therapy to people with a high Decipher score? So we're studying that both in the context of definitive radiation as well as after prostatectomy. So yeah, we have actually clinical trials across the spectrum. And I did want to mention, I didn't get a chance earlier, this lutetium-177 PSMA is so exciting as this new type of drug, but there are lots of other ones that are being developed. So I'd like to suggest maybe that Jeff Wong talk to your group. He was the chair of radiation for many years at City of Hope. He has a KLK2 targeted actinium-225 radiopharmaceutical. He has an iodine-131 PSMA. He's got one that targets the insulin-like growth factor receptor, one that targets GRPR, and many of these are that same concept. You do the PET scan, and if your tracer can show you the cancer, then you can radio label with a lethal radioparticle and kill the cancer that you can see with the PET scan, right? So these are really exciting trials and a whole other frontier, because lutetium-177 PSMA is great, but there might be an even better particle or an even better antibody that will lead to even more success. So those are some of the clinical trials that I'm also really excited about.
Thank you. Thank you, Doctor.
I have a couple more questions here. One from Bruce, and I'll see if I understand it right, Bruce. You asked the question, in light of your patients having been diagnosed in their 30s, in other words, we're talking about early onset prostate cancer, what is your take on the recommendation that screenings begin at a much later age? And I think that's the way Bruce asked the question, but reading between the lines, what are recommendations to ask to do screenings at a much earlier age?
Yeah, I mean, I'm not a screening expert, but I know there's a lot of consternation about the time period when U.S. Preventive Task Forces was recommending against PSA screening, because really a lot of men didn't get PSA screening during that time period, and yet the majority of the data really suggests that it can save lives. So I do think there are some men who need PSA screening earlier, usually not in their 30s. I mean, it's so rare. It's like 1 or 2 cases out of thousands that are diagnosed that early, right? But you look at certain risk factors. So African-American men, instead of starting at 50, really should start earlier, maybe 45. I don't know if some people are talking about 40, because this isn't my sort of main field of expertise. If you have a family member, so if your dad got diagnosed with prostate cancer at 50, you shouldn't wait to 50 to start your PSA testing, right? You should be checking in your 40s. So there are some patients or some people, not yet patients, who really should be screened early. But I think the most important thing is just people should be screened, and that wasn't happening for a while, but it is starting to happen more. I think because this is primary care providers, right? It's up to them whether they draw a PSA, whether they talk to their patients about PSA screening, and also about men going to the doctor. If you're a 35 or 40-year-old man and you don't go to the doctor, then you won't get PSA screening at all, right?
Thank you. Cal asks the following question. With increasing PSA 0.4 to 9.7 January to October after 18 months on Lupron and ABI, in your experience, is switching to Enza not effective? Also, is Provenge recommended at this stage?
So Provenge, ideally would have been utilized a little earlier. The initial data said it was more effective if you used it below a PSA of 22. Then the more modern data showed it was more effective if you used it in patients with a PSA less than 5. So earlier is better. It's not too late, but it's a little bit late to get the maximal impact of the Provenge. So how would I approach this? First and foremost, I would image what's happening on the scan. Do we have nothing changing? Well, then, you might do the Provenge, even recognizing that it may not have as great a chance of success. You could switch the prednisone for dexamethasone. That surprisingly can result in PSA declines. It's this really easy trick. I've used it probably now in 5 or 6 patients, and all but one, the PSA has gone down, all but maybe 1 or 2. So not 100%, but just to swap out that partner steroid and have you extend the life of your treatment, super exciting. If you see one area that's progressing, remember I showed you that graph from Howard Scher, PSA is rising, scan shows one area that's active, you zap that, I often see PSA drop. Again, not 100%, but those are the types of things I would be looking at. I would make sure you have your DNA sequencing, because switching to Enza is not effective, right? It's not that it works for 0 men. It's that it works for fewer men than Enza de novo, and fewer men than a PARP inhibitor would work for, or chemotherapy, right? Based on CARD and PROfound. Going from Abby to Enza is just less successful than other strategies. So plenty of doctors do it. It's not that it's wrong. You won't get as much out of it, or you're less likely to benefit from it. And so I would be looking for something else.
Okay. We hear very often about sugar-feeding cancer. Bill Power wants to know, do you have an opinion about sugar in the diet?
All right, so maybe this will be our last question. I hope that's okay. I have lots of opinions about this topic. I could probably fill a whole hour, so let me try to be brief. Warburg's data that are often co-opted to say sugar feeds cancer, that's not actually what he showed. He showed that cancer is inefficient at using sugar. So to get the same amount of energy out of it, it needs more sugar than a normal cell would need to get the same amount of energy. So people took that to mean that sugar feeds cancer. I saw some really interesting work recently that really looked at the role of protein feeding prostate cancer in particular. So I need to go and read that and have a deep think about what that means. But cancer can use anything to grow. It can use protein, it can use sugar. So, it is healthy to reduce your sugar intake, because sugar's not great for us, especially when you're on hormone therapy. There's a slowed metabolism, a tendency to gain weight, and we talk about reducing carbs. But I don't think reducing sugar will have a meaningful impact on your prostate cancer. So you should do it for other health reasons, but don't look for it to necessarily drop your PSA. When they talk about metformin being helpful, it may or may not be about sugar. It might actually be about insulin, which is where insulin potentiated therapy, I think, is wrong. If the part of why sugar feeds cancer is because sugar creates insulin, which then could feed the cancer, then you wouldn't want to be giving insulin, right? So I hope that was somewhat helpful. Again, I have lots of different opinions on this topic, so.
Doctor, can I ask a last question? Yeah.
I know Dr. Dorff wants to kind of move on. I want to thank her for her time. And it looks like the sugar and cancer topic might be something we approach in your next visit.
Yeah, hopefully I'll have more data for you. We hired this superstar new radiation oncologist who's going to be building on some of the work that we did at USC with fasting which we were studying as a way to reduce chemotherapy toxicity. So she and I are going to be looking at fasting as a way of maybe reducing radiation toxicity. So that could be something really exciting. We're also looking at microbiome, how your gut bacteria or your urinary bacteria might impact your side effects from radiation. So we're always curious, always learning. And in a year or two, I might have some data to present to you about some of that, which I think might be of interest to the group.
Dave, I know you had something, and we'll let the doctor enjoy her evening.
No, I was just giving.
Oh, okay.
Yeah, I saw a few little reactions, so thank you.
Okay.
Thank you
very
for
much.
joining this evening.
Just one thing, watch your email. We're going to have a support group second Tuesday evening in December. It may very well be the first time Prostate Forum has ever run a Zoom support group in December. Thank you very much. Have very happy holidays. And we will see you again next year for presentations, the 4th Thursday evening in January.
All right.
Thanks, everyone. Good night.
Thank you, Doctor.
Thanks, Doctor.
Thank you.